FRêMITO, o podcast vascular do perfil O Fogart da Madrugada.
Esse é o FRêMITO Podcast Vascular, direto do Congresso Science 2024, e nós estamos recebendo mais um convidado internacional, o Dr. Antônio Rizza, que é cardiologista intervencionista na Itália e vai trocar uma ideia com a gente aqui sobre o tratamento do arco aórtico. So, Dr. Antônio, very nice to have you here.
Thank you to you for the invitation to be here with you. It's a very pleasure.
So it's possible to treat the aorta arc by endo?
Yeah. The history began some years ago because nowadays the treatment of aortic arch is open surgery.
Uh-huh.
But we know that there are some aspects. We can begin about the possibility to do increase the procedure on aortic arch, because we know that aneurysm and dissection involving aortic arch are increased in the last year, but we know that also that the possibility to have more case in the next year is very, very high, because if we take a look to some paper, we can learn that about 50% of patients with aortic dissection or rupture aneurysm died before to arrive to the hospital or during transfer from spoke to hub center. And this kind of patients are excluded from the must trial, included the international registry on dissection. Then we have to start from this patient, because the schedule of incidence of dissection in over the next few decades are double than now. Then we will we will treat a lot of patients more than now. However, we know that for a lot of group, like Coselli group, like other group, they consider still open surgery the best option for the treatment of arch lesion. But we know that they have good results. At 8 years follow-up, survival of more than 16%. Then good mortality, but there is a problem: neurologic complications that are very, very high, despite the advantages of a new cerebral perfusion technique, but remain very, very high. Then what we have to do? We have to think about other than hybrid technique or total endovascular technique. For the first hybrid technique, we worked a lot with this kind of technique. We have to need an aortic team, because we work together with the radiologist, with the cardiac surgeon.
Sure.
Then it's typically a double procedure. First step, open repair, after followed by a endovascular treatment. These two kinds of treatment can be performed in the same stage or in two stages separated. we prefer two stages separated because reduce the risk of MACE, of major cardiovascular accident. But it's we know that we have our data, unpublished data, unfortunately, but we know data from San Raffaele Milano, Chinese data that confirm good results in terms of mortality, about 2% of mortality with 6% of stroke or cerebral accident. But if we compare the hybrid versus total open procedure, we can see that mortality is in favor of a hybrid technique because it's less invasive than total open. In the other hand, for neurologic complication, the results are in favor of open technique. Okay. Then, what we can think about these results? We have to find another way, and then we think that total endovascular procedures, like in other aortic district, we can think about abdominal, who in 2024 prefer open surgery.
Of course, yes.
Respect endovascular treatment. Then we know that the history of aortic treatment is moving toward.
It's an evolving technique. So.
Yeah, is moving.
It's very dynamic.
To less and less invasivity.
And Dr. Rizzi, may I ask you? Obviously, is a huge challenge to treat this type of patients. The proximal and distal end zones are challenged, and to revasc the supra-arc vessels too. So what type of process do you have in Italy to treat this type of patients?
It depends of the proximal landing zone area, zone. If I begin from the more simple, zone 2 area, zone 2 zone, because there are nowadays two kind of custom-made or semi-custom-made device, like monobranch by Gore and a monobranch by Castor by Microport, Chinese company. I had a great experience with the second, with the Castor. I performed more than 15 patients with this technique. My results are that 100 success procedure, 0 mortality, 0 stroke, at in-hospital follow-up.
Yes, for landing 2 is perfect.
Yeah, later, 0 endoleak type 1. That's very, very interesting because this is a kind of endograft that has a precannulated branch for the left subclavian artery, and it's very interesting because in this way we reduce the risk of type 2 endoleak from the left subclavian artery, and we have 0 endoleak.
Sure.
Nice.
And to go ahead and landing in zone 0 or zone 1.
Do you prefer Castor or customized?
Okay, in just 2 or 3 months ago, I performed in a Chinese young girl with intramural hematoma, with the pain, recurrent pain for 2-3 days, resistant to the best possibility to use drug in this case. And we decided to treat her, but we have just a castor, because you know that the possibility to use custom device that are an high possibility to have a success procedure require 4-6 weeks for design, for construction of the endograft. Then I have a castor, and I performed a carotid left subclavian bypass, and I deployed the branch of the castor in the left carotid artery.
Good option.
She had a minor stroke, but with complete recovery in 1 week.
So you can still use hybrid procedures?
Yeah, in this case, yes.
Okay.
But in the other case, we use IFU indication.
Okay.
For zone 2 or 1, we had experience. We had experience so in zone 0 or in ascending aorta. We are working with the braille to an important, according to me, we are working to the project of an ascending aortic device for endovascular treatment, total endovascular. Why?
Yeah, we know that you have like some good experience for the past years with Brazilian endograft of Braille industry. So can you tell us about this?
I worked with Braille from 80 years ago with good results about arch lesion with the fenestrated device, and the last time with branched device. I think that we have two possibility to approach aortic lesion with this kind of device that, according to me, is the more complete possibility to have customized endograft, and that's about arch lesion. For the ascending arch, for the ascending aorta, we are working to this project. We are working because we think that about 20 patients that arrive in cardiac surgery for a type I dissection, 20% of patients are excluded from cardiac surgery because they are at high risk or very high risk for cardiac surgery. Then we think that we know that the natural history of a patient with the type A dissection is the dead. Then we have the possibility to offer to 20% of patient other possibility.
So in these cases,
we can offer. Why not?
Yeah.
Why not offer endovascular treatment with the possibility to failure, but you offer something.
It's better than nothing, right?
Exactly.
Yeah.
Yes.
Okay. Nice.
It's good to know that you have an option to treat these patients.
And we are working in this project. And the objective is to close, obviously, the first tier, the proximal tier, with a lot of problem because we have a lot of experience on ascending aorta with device no fit for ascending aorta. I used a lot of device like coils for pseudoaneurysm, post-surgical treatment, or cuffs from other company, or occluder PFO occluder, just to close the hole of the pseudoaneurysm. But obviously our
main goal.
yeah. Okay. Then we are working to this project to give to the patients the opportunity to go ahead.
Amazing, Dr. Rizza. We are very happy to have you here, and I know that all the guys here in Congress learned so much with you. Thank you very much.
Thank you to you.
Não deixe de continuar acompanhando os episódios do FRêMITO Podcast Vascular, direto do Congresso Science 2024.
FRêMITO, o podcast vascular do perfil O Fogart da Madrugada.